Again, welcome back after the break, and wow, all I can say is what a morning. If that didn't affect one, all of us and none of us or some of us in any way, it was just really, really heartfelt. I'd like now, it's my pleasure to introduce our next speaker for the second half of this morning, Dr. Robert Wallace. His topic will be HIV/AIDS, where are we now? Dr. Wallace is a family practice specialist, again, in the St. Petersburg area here in Florida, one of the pioneers in the treatment of HIV and AIDS. He was one of the founding board members, importantly, of the organization that would come to be known as the American Academy of HIV Medicine. Dr. Wallace, thank you very, very much, and welcome to the Southern Medical Association.
Thank you. Am I on? It's green, yeah. It should be. Is it on? Okay. Good morning.
Okay, Robert. Bob, you okay? You got everything?
Yeah, I think we're on.
Good.
Thank you to the Southern Medical Association and all of you for being here and the chance to speak. The topic is HIV and where we are now. Those presentations were so awesome this morning, it's kind of hard to follow that kind of a presentation.
I'm sorry,
But what I will do, based on what she said, I want to share a little bit of my personal story and what's going on. For those of you who live in St. Petersburg, we've already done a 15-minute documentary that will be shown at Gulfport Library on November 30th in honor of World AIDS Day. And that's a preview to an hour-and-a-half documentary that we're trying to do, looking at 30 years of AIDS from a doctor who lived it here in St. Petersburg.
So when is that going to air?
You can go to YouTube and look up Tapestry and put my name, and you can see that 15-minute clip. It's a preview to what we're going to be doing. So let's get started. This lecture has certainly changed over the years, and part of the story I wanted to share is I saw my first HIV patient back in 1983. We had nothing. There was nothing we could do. We just basically held hands and helped people die. I started getting more involved in clinical research around 1988, and at that time, the pharmaceutical companies that were doing research would pull a group of us together, and we were there every other weekend. We were at some major city. There was a group of about 60 of us physicians that were trying to help find something that would stop HIV. The challenge was many of the physicians who were there doing it had HIV themselves. So each time we would go back, there would be another one or two physicians not there. So we talk about PTSD and the stress of that. It was very, very stressful to see not only our friends dying, but our colleagues dying, and we remember them gratefully. They've done a lot of great work during that time period. Didn't move. There we go. Takeaway concepts. Basically, we're going to give you a brief HIV update. Many of you have probably had the HIV update. I've been asked to give you the information that you need so that you can get CME credit. Many of that may be a little bit boring, but then we'll step into what's going on and where we are now with HIV. When you look at the data from the CDC, it's always interesting that this was presented at the 2017 CROI conference, but the data only goes up to 2014. The interesting part and helpful part is that the cases of HIV in the United States had decreased by 18% during that time period up to 2014. The belief is we're still seeing some decrease in what's going on, but there are certain groups that actually are at risk, and it's made it a little bit harder not to sit back. We need to get back out there giving the message about HIV and talking to our young people about the fact that this virus is still deadly and it's still here in our midst. 20% decline in new infections between 2005 and 2014. But women decline 42%, but make up 60% of all the new infections. When you look at men who have sex with men, still 67% are the new infections, but the group that's being most highly represented is young men of color who have sex with men. And you'll see that that increased by 87%. And that number continues to increase now. When we looked at the number of cases of AIDS throughout the states, Florida was always number 3. And in 2016, Florida actually became number 1 in the number of cases of HIV being reported around the country. The other disparities that you have to think about, African Americans make up 44% of all new cases, but only 12% of our population. When you start talking about poverty and going into the South, where I spend a lot of my time, 44% of the infected live in the South, but they only make up 37% of our population. What we do know is that if we can get people treated, we could stop the spread of the virus. If we look to our colleagues across the border in Canada, where you can get medication for treatment, and looking at this data, I want you to pay attention, is up to 2012. Look at the decrease in the number of cases and incidents of HIV just by getting people on combined antiretroviral therapy. You'll see that there was a decrease in mortality from 6.5 to 1.3 per 100,000. New cases dropped from 702 to 238. And the incidental cases from 632 to 368 cases. Here's the basics of the HIV transmission. The reason I put this slide back up here and say we have to go back to our basics is I'm now going around and hearing groups where people are misinforming people and telling people that the virus can survive outside the body for up to a week, and that's not true. Hepatitis C, that's a different story. But HIV, it doesn't. It needs a blood-to-blood contact. These are the risk exposures. This is what we know most about and how we see most of our people getting infected. What's happening today with the opioid epidemic, we're having an incredible number of people, and particularly young people, that are showing up HIV positive. There was an incident in the state of Indiana while our vice president was the governor of that state of Indiana, that they found a rural area that all of a sudden there were 167 cases of new HIV infection that showed up. When the CDC went up out of concern and great fear of what was happening, it was in the rural counties of Indiana, and the problem is it was based on the opiate addiction, and they were all sharing needles with one another. Many of them were related, family related, or distant family members. It took the CDC a little bit of time to convince Governor Pence at the time, but he did offer a needle exchange program in that part of the state, and it started reducing the number of new cases. Needle exchange would reduce the number of new HIV cases. Here in Pinellas County, the thing that we are seeing is our population is aging, and we're beginning to see more of our patients, many of the patients that I cared for now in the 1980s are now in their 60s, and some of them in their 70s. The other thing about HIV is it is an inflammatory disease, and it's actually an age enhancer. What we have to look at with your patients with HIV, they're actually about 10 years ahead biologically of what they would be in their age group. So you're looking for cancers, you're looking for COPD, you're looking for CHF, you're looking for diabetes 10 years earlier than you would be in your general population. The diagnosis has changed. We do not use the Western blot and ELISA anymore. That was something you were probably all familiar with. The new 4th generation antigen antibody test will detect the virus in as little as 3 weeks after exposure. So we don't have this problem where we have to wait 3 months to keep retesting people. If you have someone who's come in who's been exposed in the last month and you get this negative test, you're pretty clear that it's okay. The primary infection is the acute infection. 40 to 90% are associated with symptoms. Many of these are people who show up in the emergency room with what looks to be the flu, and they don't really get treated. They get sent back out unless questions are being asked as to what's happening. And to the defense of the ER doctors, there's just no way of really detecting unless you have the time to do a whole social history and get down to what's happening and what's going on. And I appreciate Dr. Pell and what you're saying about now that we question and we have more questions on our electronic medical records, we can sometimes pick these things up a little bit earlier. The initial viremia, the viral load will go very high, and I'll show you a little bit about the progress of disease in a second. The most common features are fever, fatigue, and you will see rash. But fever and fatigue are generally the most common symptoms that will show up in an acute infection. There's a lot of studies and actually funding available for different community organizations that are doing what we call test and treat now. And what we're doing is once a person tests positive, we're trying to get them into therapy immediately. And we'll talk about what the recommendations are and how they have changed. The virus targets a cell called the CD4 cell. It's the only cell that the virus does infect. Animals don't have CD4 cells, that's why they don't get HIV. And we will see that there are different targets that we can hit to stop the virus. When I first started, we only had one drug focusing at one target, the NRTIs. And we saw then that only using one group of medications or hitting it at one target was not successful. So when we look at the life cycle of the virus, you start kind of at the, you said there's a laser here, right there. At the virion coming in, getting close to the CD4 cell. It identifies the CD4 cell as the one to infect. There's a specific receptor known as CCR5, and the virus will then be invited by the CCR5 receptor to come closer to the cell and then fuse into the cell. When you see the fusion occur, where we had our first drugs were here, where we would stop reverse transcription. This is a retrovirus, so it needs your genetic material to keep replicating and keep going. These drugs that were first produced were pretty much fake copies of the nucleosides that we have in our body, and as the virus would try to pick up nucleosides trying to replicate itself, it would terminate the chain because they were lacking one particular side chain, a hydroxy group, that would not allow the next nucleotide to come in. So they were chain terminators. Then we've learned over time, one of the groups that helps us the most is when we got to the protease inhibitor group. And when that happened, and we started combining NRTIs with protease inhibitors, that's when people started living. And the most popular case that brings to light what happened was Magic Johnson. And Magic Johnson was diagnosed right at the time, 1995, 1996, when what we called the drug cocktail was available. So he got started on that medication. And there were many people that were saying, hey, you know, why is he getting special treatment compared to everybody else and he's living? And the other thing that happened is his wife had gone on public media and said he doesn't have the virus anymore. That created a lot of confusion that we had to really work with patients. And what was happening is at that time we were able now to detect the virus in the system by PCR testing, and we could detect down to 200 copies. So anyone below 200 copies was considered undetected, and people were misinterpreting that as saying that the virus is gone. So we had to work with that for quite a while. The integrase inhibitors have come up now and are more popular, and I'll talk about those in a minute. The guidelines, the most common guidelines are the DHHS guidelines. They do get reviews twice a year. It's kind of slowed down a little bit now because most of the drugs are on the market and we do have them. But what has changed is the recommendations are if you're using a protease-based regimen, the drug darunavir is the one that's picked as the first choice. The NRTI, the integrase bases that are used are the dolutegravir, elbiterravir, and raltegravir. Those are integrase inhibitors, and they're available in combinations. I got a next slide that will show you some of the combinations. On the bottom are listed the alternative regimens. These are the regimens that we had used frequently in the past. There is a combination pill with a drug called Truvada and rilpivirine. It was marketed as Complera. It's now called Odefsey. It's a one pill once a day, but you have to be careful. It needs to be started in patients who have a viral load lower than 100,000. The other regimens are more potent, and we need to know that we're starting the right one at the right time. So, the International AIDS Society, who has an annual conference now, worldwide conference, they also are well recognized in terms of providing guidelines for us. And what you'll see that has happened is that in the guidelines recently, we've started recommending integrase inhibitors in combinations with the old drugs that you may recognize as AZT or Truvada or Epsicom, as opposed to using the protease inhibitors first line. And that's made a big difference. The second thing that has happened that I'll explain to you now is the drug tenofovir, when it was first approved in 2001, we really found that was a drug that was going to kick butt. It was going to stop the virus from spreading, stop the virus from replicating. It's been studied to see if we can use it in prevention, and we do. We'll talk about that in a second. But the formulation changed, and the formulation change was pretty significant. The original formulation was tenofovir disoproxil fumarate, called TDF. We used the 3-letter numbers. With the TDF, it would get into the cells fairly quickly, but it also stayed in the plasma, and one of the effects was it would decrease bone mineral density and it would increase creatinine a little, but they stayed stable. It didn't keep changing. It was just something that was noticed. There was a change, and a lot of providers were afraid to use it, but it is now the #1 product used throughout the world in trying to treat HIV infection. So they changed the formulation to tenofovir alafenamide, which is TAF. The nice thing about TAF is it goes directly into the cells, it doesn't hang around the plasma, and you don't see the changes with bone mineral density, and you don't see the changes with renal effect. When they did the comparison of the new formulation compared to the old formulation, as you would expect, it did as well. It actually did a little bit better with the TAF-containing regimens getting undetectability and keeping undetectability now. Some of these studies are out 10 years, and these patients are still undetectable. So we see that big change. The variable life cycle of the virus, most people will follow the typical pattern. This was the area where in the older times we thought there was a latent period, and there's no latent period with HIV. The virus is constantly replicating at 10 billion copies a day, and our body is trying to create CD4 cells to fight that off. But there are people with different patterns. Some people will be, rapid progressors, where they will suddenly have their CD4 count go down and HIV go up. There are people that we call the non-progressors, and those are patients that will stay on drug for years and years and years and just not progress. I'm not going to go into the whole detail, but I'll throw this out to you just as a point of interest, is we now know that on the genes that we have, there's a certain position at 32 on the CD4 cell and CCR5 receptor, that if you've inherited a defective allele from both your mother and your father, you are immune to HIV. And the proof that we have of that, if you want to write down the Berlin patient, you can Google the Berlin patient and get the history. It was a young man in Germany who developed lymphoma, and they did a bone marrow transplant. They actually found a patient who had the double delta 32 mutation in his system, and that was the donor who took care of the patient who had the leukemia. They had to do a second transplant. The first one failed. But within 2 years, they cannot find HIV in his system. He's the only patient that's been known to be cured of HIV. The initial visit, pretty standard in terms of what you're doing. You just want to make sure you're doing a good history and physical and a reasonable exam. The initial labs, fairly standard. The only differences here is we look for an HIV genotype. You want to find out what the virus looks like before you start treating it. The HLA-B5701 test is specific for a drug called abacavir. If people are positive for the HLA-B5701, they are likely to experience a severe rash and a severe allergic reaction to this drug. So if you're going to be providing abacavir, which is now in 3 different products in combination, you want to make sure that you know the patient is a 5701 negative. Hepatitis panel is really important, and we're beginning to see that as we go on. Monitoring now has become a little bit easier. When we're looking at monitoring, and it's kind of like we talk about the empty nest syndrome and letting our kids go away. Those people like me, we did blood work every 3 months. You had to do it every 3 months. You had to keep the CD4 count. You had to do the viral load. You had to make sure everybody was doing well. But now with these new miraculous drugs that we have that are keeping it in check, what we do know is that if patients stay virologically suppressed, we only need to do the viral load twice a year. If their CD4 counts are remaining stable, we only need to do a CD4 count once a year. And that's kind of hard for the patients that have been in this disease state and you're telling them you're cutting back on their blood draw. They get really nervous about it. But for the new patients coming in, that's the standard of care. Once you've got them past 2 years and they're stable, you could do a viral load every 6 months and a CD4 count once a year. All right, this is just the amazing change from back. In 1988, I had a slide and it had 2 drugs on it. There were 2. These are all the different classes that we have, and I won't get into the branding to stay unbranded on my lecture, but it's just amazing the combinations that we have. The fixed dose combinations, putting 3 to 4 drugs in 1 pill once a day, have been phenomenal. All right, are there new drugs coming? Yes, they're still looking for newer agents to try to help combat this disease. Bictegravir, under the integrase inhibitors, that's actually II up there on the top. It's number 2. The integrase inhibitors, that drug was actually put up before the FDA as a new drug application in combination with the drug tenofovir and emtricitabine as a single 1 pill once a day regimen that will go again to be approved. The advantage of that drug, when we start looking at its efficacy and then the one just underneath it, both of these drugs can treat resistance that may have occurred to the earlier integrase inhibitors. That's been our big fear. If patients don't take their drugs and we as doctors don't write them correctly, people will get resistant and you can infect other people with your resistant virus. So we want to avoid that. So the guidelines, as I said, have changed. The integrase inhibitors now are pretty much what's used in combination with the nucleoside reverse transcriptase inhibitors. If we're using the protease inhibitor, the one most preferred is darunavir. Just to give you a brand name, that's called Tivicay. If you have patients coming in on Tivicay, that's darunavir. It is a protease inhibitor that needs to be boosted. The backbone, we still use tenofovir and emtricitabine. That is still the standard. The older formulation with TDF and emtricitabine, it's only for people with their creatinine clearance is greater than 70. The newer TAF formulation can be given to patients even with a creatinine or GFR of 30, and it can still be given without causing renal problems. So it's been a big advantage. When do we start? This has been the big change. I had the chance, I did get one publication in my life. In one of the journals, I wrote a paper back in 1991 saying, you know, we don't wait till our diabetics get neuropathy and retinopathy before we start insulin. So why are we waiting until our patients get immune compromised before we start HIV therapy? And this pendulum went all the way down to the point that because of the toxicity of the drugs that we had at the time, people were delaying starting therapy until people got to a CD4 count of 250. And when you get down that low, it's harder to bring people back up. So it took quite a while for the people and the agencies to begin to recognize that we can reduce morbidity and mortality if we start patients immediately when we find out that they're infected. We don't need to sit and wait. What drugs to start? Pretty much use the guidelines. 3 drugs are better than 2 and 4. And when we say 3 drugs, just remember these are all 1 pill, once a day combinations, and they generally have no side effects. I mean, that's kind of amazing you get to stand up here and say no side effects. When we started using the protease inhibitors, one of the first ones that came out was a drug called Norvir. It was in a capsule form, and you had to take 6 capsules twice a day, and one of the emollients in it to make the drug work was castor oil. You want to know what the side effect was? You couldn't go to work. Literally, patients couldn't go to work because they would have accidents. So that's how far we've come with these drugs. Less pills are better. Again, combinations, there are newer combinations coming that will be later this year. And a follow-up visit is fairly typical. You basically want to continue to follow your patients as you would normally if they're stable. You just look at a general physical examination and maintaining. We've already talked about blood monitoring and what needs to be done. If you think there's anything else, you get a little bit more specific with your examination. Once again, just keep reinforcing this because we're seeing with so much happening in our insurance world, whatever is going to happen in our insurance world, and all these requirements, we're being graded as physicians. I have one Medicare company that was requiring me to do a telephone conference once a month to review my drug costs and lab costs of what we were doing. So it is important that we know we don't have to be doing all these excessive blood draws and laboratories that cost money. We can monitor them and do well. Don't forget vaccinations. Patients should have a flu vaccine. The herpes virus injectable, you want to make sure their CD4 count is above 200. If it's below 200, they won't give it. This is a problem for me where pharmacies like Walgreens and CVS are the ones distributing and doing these injections without actually getting a full history from patients and not knowing. I did have a patient who had a CD4 count of 100 who got the reaction and ended up with shingles on the front side of his face. So we have to watch for that. A and B hepatitis, we can get people immune for that. Again, this is kind of a repetition of everything that I have said. So I want to get into the more popular stuff of what's going on now. How many of you are familiar with PrEP? If I say the word PrEP. Good. Good, good, good. Have any of you written PrEP prescriptions? Okay, so good. So we're seeing the younger providers are more in tune with this and know what's going on. When we look at post-exposure prophylaxis, this was a big concern for us back in the earlier days, and I always kept drugs in my office from people who had died. They would give us all their drugs, so I always had a drugstore of AZT, 3TC, Crixivan or efavirenz, so that if somebody came to me and they had a needle stick, I could get them started on the pills right away. Because as you know, try to do a prior authorization and get your patient started in 72 hours after infection. It doesn't happen. So we have to have ways that people can really get their post-exposure prophylaxis right away. You want to administer it as soon as possible, less than 72 hours. 3 drugs are the combination that are going. Tenofovir emtricitabine is a drug called Truvada. Truvada is very, very popular, and we'll talk about that when we're talking about PrEP next. And again, the switch has been from the protease inhibitors and NNRTIs to the class called the integrase inhibitors. So raltegravir is a drug that's chosen if you have an employee that gets infected and needs to be treated. It's a 28-day treatment. Okay, nPEP, non-professional exposure. These are the patients who are victims of rape, people who have had an incident where the condom broke. I hear that a lot. And people just not using condoms and realizing they've made a mistake. The same guidelines are pretty much there. You want to get people into treatment within 72 hours and get them started on these medications. And the drugs tenofovir and emtricitabine have been studied for so long in so many countries, it's very clear that they will prohibit the virus from infecting a person if you get the patients on treatment before 72 hours. It's effective. It's almost 93% effective. You look at the ones who are at risk. We see lots of different things happening in our young people today with sexual exposure. I'm now running a hepatitis C clinic, and you'd be surprised at how many heterosexual couples have anal sex to avoid pregnancy. They can't afford the birth control and don't have any other options. When you have patients who are one is positive and one is negative, that increases the risk for HIV and hepatitis C. If the person who is infecting or could infect the other person, if the viral load is high, that's a much greater risk. If it's a bloody membrane or there are genital ulcers, this is why we keep talking to kids about STD screening and make sure you're clear of STDs. If you have an STD and you're having sex with someone who's HIV positive, you increase your risk of getting infected. And the preferred regimens pretty much are, as I said, the same. They're not any different. All right, now PrEP. This has been a really controversial topic. And having been around as long as I have, I lived in San Francisco in the 70s. And I can tell you, if any of you were that young and in the sexual revolution, you could have sex in the grocery store if you wanted to. And what we're seeing is with all this media and social media now, young people are having sex 2 to 5 times a day with different partners because they could do it right on their little Grindr or Scruff or Men for Men. And they're out looking, and we're seeing so much more exposure to people with the risk of getting infected. So PrEP, or pre-exposure prophylaxis, is recommended for an adult male without acute infection, any male with sexual partners in the last 6 months, patients that are not in a monogamous relationship, and they need to be tested frequently in terms of what to do. And at least one of the following: if they've had anal sex without a condom, if they have an STI, as we've already talked about, or if they're in a relationship with someone who's positive. And this applies to the heterosexual population too. I have many patients where the woman has been infected and the man doesn't want to get infected, so we put the male partner on PrEP. And the same thing in reverse. The male partner is positive and the woman doesn't want to. And what has been shown, and this is where the controversy comes in, it's been shown to be so effective that there are groups out there saying you don't have to use condoms if you're on PrEP. Now, I'm part of the American Academy of HIV Medicine and on the steering committee for the Florida Academy of HIV Medicine. And the groups are trying to get the organization to condone this or support it, and we won't. And it just won't. You can't say never. Never say never. All right? Again, pretty much the same thing of what I was just talking about. Patients who've had high-risk behaviors, you definitely want to make sure you're getting them in and talking to them about sexual activity. How many of you ask your patients over 60 if they're having sex? Good. You've caught up. Yeah. It's really hard. When I first started doing this, I had so many patients in my practice that were like my grandparents, and it was so hard to have this discussion, but I got really used to it and talking to people about having sex, and I'll tell you, it's kind of interesting. When you start asking, they'll tell you some really good stories about how active they are. You know, go up to the villages here in Central Florida and see what's going on. All right, PrEP, as I told you, Truvada is the drug that's being used for that. It is a one pill, once a day treatment with minimal side effects. Patients need to be informed. You do not want to give them more than a 90-day supply. Insurance companies are paying for this. It requires a prior authorization. Your staff has to be fairly savvy in answering the questions and knowing what they're doing. There are organizations that are really good at that. If you had someone for PrEP, I'd be happy to see your patients for you and talk about it, because it is another level of intensity in terms of time engagement and getting people onto treatment. But you want them to continue the treatment for as long as the risk factors are there. The other thing about PrEP is the CDC guidelines recommend if you have patients on PrEP, they should have STD screening every 6 months. Syphilis, gonorrhea, chlamydia, hepatitis C. And syphilis, said already. All right, HCV co-infection. This is how I kind of got my feet wet in doing hepatitis C. Is 20% of patients with HIV have hepatitis C. So I started treating hepatitis C back when we had the old interferon that was worse than anything you could give anybody. And then we had the combination of the interferon and ribavirin that was about 60% effective. And one of the reasons I'm in practice today is I started working at the health department back in 2015. And my clinic is called Love the Golden Rule. It's about treating people the way you want to be treated yourself. Because in working at the health department on the medical mobile van, I couldn't stand the way people were being treated. And what's happening is there is this huge population of hepatitis C infected patients in our population. And it's getting worse. It's related to the opioid epidemic. It's related to needle injections. I work 2 mornings a week at a methadone clinic. July 28th was World Hepatitis C Day. I randomly took 22 patients standing in line getting their methadone, and 12 of them tested positive for hepatitis C, and only 1 knew they had it. So hepatitis C, put that on your radar. Hepatitis C co-infection is there. The treatment with the hepatitis C drugs is equally effective, and you can see that patients do well with the direct acting agents, the Harboni, the Epclusa. We have a new one now called Mavorite. And these drugs with Mavorite, which is so amazing, you can cure hepatitis C in as little as 8 weeks of treatment. I have to stop and let you catch your breath. I had to catch my breath with that. That's why I'm in practice. It is awesome to be able to cure a virus that's deadly in 8 weeks with 1 pill once a day. It's absolutely amazing. But the co-infected patients do need to be treated because they are at greater risk for having comorbidities and other illnesses. Opportunistic infections. This is something we learned back in the 1990s, is that when patients come in and they have a severe or have had an opportunistic infection, you want to be careful about suddenly starting them on these highly potent antiretroviral drugs. The story I tell was a friend of mine. His name was Steve. He was a bodybuilder. He had CMV retinitis and had lost most of his vision. He couldn't drive at night anymore. We were very, very close friends. I saw him every day. He came in right when we got the new protease inhibitor drugs, and this is where we learned about this syndrome called IRIS. IRIS, not that. IRIS. It's immune reactivation inflammatory syndrome. And what happened to Steve, he'd never had a CD4 count above 100. We had never been able to get his HIV infection undetectable. His CMV was so bad, he was on daily infusion therapy, just trying to save his vision. And we got so excited when he came in after 4 weeks of being on combination therapy that his CD4 count went above 200. And a week later, he was paralyzed because the CMV hit his spinal cord, and there was nothing we could do. He got out of the hospital, and I actually had to piggyback him on my back up to his second floor apartment until we could get him into a first floor apartment. And he ended up dying because we couldn't treat it. So this IRIS is something you have to really consider. And it becomes important with MAC, TB, cryptococcal meningitis, and with CMV. TB is something that people talk about. There's a lot of discussion of when you start and when you don't start. I know you all aren't treating. I'm just hoping I'm giving you pearls and education that you don't have a chance to get anywhere else. But you want to get patients started on their TB treatment first and then get them into their HIV treatment. And lots of studies have shown exact time or when you should or when you shouldn't start treatment. Just remember that these TB patients have extrapulmonary disease. I've got all these stories that I just have to tell you. What time is it? 11:08, I'm okay. I had this young girl come in that, this was back in the 90s, and we had an HIV ward at William and Mary Nursing Home. And she used to sit in the window and wait on me because I did a spinal tap on her every Friday because she had this meningitis. And we suspected that it was CMV, going on and on and on. And we kept testing and found out she was TB positive. We could not get her to stay in the unit. She would escape, she would come back out. And this is back when we had, I think it was in Lantana, Florida, we had the TB hospital. Remember where the TB hospital was? And she ended up being sent there because we could not get her treated. And what was going on is she actually had a tuberculoma of the brain. And the doctors wrote her case up and submitted it, and it was published because it wasn't just cryptococcal meningitis. I was wrong. She had a tuberculoma of the brain, and we just weren't getting her better. We couldn't get her to take her medications. She wouldn't stay with it. She eventually died. All right. These are the latest treatment guidelines. As I said, you can find them on the DHHS guidelines. The International AIDS Society, IAS-USA, has great guidelines, and they update them constantly. The other websites you can go to, and one I'm pushing and continuing to push, we need more people and doctors interested in HIV to join the American Academy of HIV Medicine and become HIV specialists. We don't have enough people to do this. Nurse practitioners can get this specialty degree. Pharmacists can get this specialty degree. And it really helps us to know that your patients are getting exactly what they need when it comes to HIV. It is simple that we can treat them, but it's complicated. You have to know what you're doing. So I appreciate and thank you for your time.
Are there any external questions? Could you check while we're going to pass the box around?
Does anyone have any questions?
The session is open for questions and discussion.
So you mentioned that someone who gets exposed today won't be positive for 3 weeks. There's a 3-week window of identifiability. In other words, when someone would test positive for HIV exposure, that's a 3-week window from exposure to testing positive?
The new 4th generation test can identify the virus in as little as 3 weeks after infection. The ELISA and the Western blot, it took up to 3 months for people to develop those antibodies. So this is just the fact that we have a new way of testing and doing screening that you can tell if your patients may have been infected within the last 3 weeks. This is just something that's amazing that we have this availability. It's not about any latency period or infection. It's just that we now have a test that we don't have to sit and wait 3 months and have your patients going through treatment and fear and waiting to keep coming back for that 3rd month follow-up to find out if they're negative. It's now within 3 weeks we can tell them.